Hello and welcome. I'm Dr. Ingvild Olsen, the Director for the Center for Substance Abuse Treatment here at SAMHSA. We are very pleased to be able to offer this webinar as you prepare your FY22 application for the SOAR grant program. As you know, the SOAR program aims to address the overdose epidemic by increasing access to treatment using FDA-approved medications for the treatment of opioid use disorder, reduce unmet treatment needs, and reduce overdose-related deaths through the provision of prevention, treatment, and recovery activities for opioid use disorder. Using SOAR funds, states and territories have implemented evidence-based practices using several effective and innovative approaches over the last several years. These approaches have resulted in positive outcomes, such as significant increases in client engagement, satisfaction, and retention in care, enhanced transitions for clients re-entering communities from criminal justice settings or other rehabilitative settings, increased naloxone availability, improved integration of wraparound recovery support services, successful family reunification and improved outcomes of child welfare involvement, and expanded access to on-demand treatment. While the SOAR grants have had positive impact across the country, as you are likely aware, we are continuing to lose too many lives to overdose. Provisional data from the CDC indicate that over 100,000, close to 105,000 now, people have lost their lives in the 12-month period that ended last October. We've also seen that some communities are being hit harder by overdoses compared to others. We also know that a proven strategy to reduce overdose deaths is education on and purchase and distribution of naloxone, the medication and a medication that reverses opioid-related overdoses to save lives. And through SOAR funding and other sources, states have been providing naloxone to their communities for some time. But the significant increase in fentanyl-driven overdose deaths that have been accelerated by the COVID-19 pandemic means we need to do more. And that is why, as part of the FY22 SOAR funding announcement, we've included a naloxone distribution and saturation plan that particularly pays attention to areas and communities with high rates of overdose mortality. To support you in fulfilling the plan and the requirements that are in the application, SAMHSA has partnered with the Opioid Response Network, ORN, to provide you free training modules. These modules include an overview of a modeling study to estimate the number of naloxone kits needed to reduce overdose risk, perspectives from urban and rural settings, and insights from the recovery community. We hope that these modules provide valuable information and insight as you develop your naloxone distribution and saturation plans. We so look forward to continuing to work with you and everyone in every community across the country to make sure that we are continuing to save lives of those impacted by this overdose crisis. Thank you.
Hello everyone, my name is Dr. Kelly Bryant and I'm Assistant Dean of Clinical Affairs and Simulation at Columbia University School of Nursing, and I'm also the Medical and Program Director of our own Opioid Overdose Prevention Program here in New York City. I'm here today to present a presentation on best practices and tips for opioid education and naloxone distribution. Some of the objectives for this presentation are, at the end of this presentation, the participant will be able to discuss effective strategies for conducting naloxone training, implement resources for developing an opioid education and naloxone distribution program, and lastly, describe process for becoming an opioid overdose prevention program. Just want to start with some of the latest statistics. Opioid overdose deaths are on the rise since COVID. The latest statistics show that there's about 96,779 drug overdose deaths between March 2020 and March 2021. And that is a 36.1% increase from the previous year. And opioids are a factor in 7 out of every 10 overdose deaths. And fentanyl plays a significant role in a lot of those overdose deaths. So before I go into this presentation, I just want to be aware that you need to check your own naloxone distribution laws by state because they do vary state by state. So there's a wonderful website, as you can see on the bottom of the slide, where you can go and you can see all the laws dealing with naloxone distribution. and it goes again by state. And this is just a quick slide to show that naloxone distribution access also varies by state, with states in pink having standing orders. States in green have pharmacist prescription authority only. And then the states in blue have statewide standing orders. So again, you need to check with your state to see what your laws are regarding distribution of naloxone. And we know that naloxone saves lives. A survey from 2014, and although that's old, that's the latest study that we can find that really shows that distributing naloxone saves lives. And this was looking at 136 organizations that conducted naloxone training between 1996 and 2014. And they were able to document over 26,000 overdose reversals using naloxone. So as you know, it's very hard to track because we're distributing naloxone on so many different individuals, and we really depend on people reporting back to us, which can be difficult. Another large-scale study, national study, showed that opioid overdose deaths decreased by 14% in states after they enacted naloxone access laws. And lastly, high rates of naloxone distribution among lay persons and emergency personnel could prevent up to 21% of opioid overdose deaths. And these all come from research that has been done recently. So when you think about creating your own naloxone education and distribution program, some of the things that you really want to make sure that you cover in all trainings are a description of what are opioids. And we can have a description about opioid overdose deaths without talking about what is fentanyl and what role does fentanyl play in the increase in the deaths that we're seeing. What is naloxone? So describing the medication and the safety of the medication. How to recognize an opioid overdose. So you want to go over all the signs and symptoms, such as the decreased respirations, decreased level of consciousness. How to respond to an opioid overdose. How to use your naloxone kit. How to first try to wake the person up to see if they're conscious or not. And then all the steps to administer naloxone. Most naloxone now is nasal format. However, depending on your state and what you'll be distributing, you may have to go over how to administer auto-injector or subcutaneous naloxone, again, depending on what you'll be distributing. And the importance of calling 911. And also cover rescue breathing. As we know, when it comes to opioid overdose deaths, the first sign and symptom that leads to death is decreased respirations, and eventually respirations stop, and then therefore the heart stops. So just by teaching individuals how to administer rescue breathing can save a lot of lives. Aftercare. Once naloxone is given, once 911 has been called, what will the respondent do after that? So such as putting the person in a recovery position. And then lastly, how to obtain naloxone. Where can they get it? Can they get it from their local pharmacy? If they use their kit, what should they do? Should they contact you for another kit? So these are all the core topics that we want to make sure that you cover in any of your naloxone trainings. And if you have time, and depending on your audience, you may want to add in some additional content. And additional content, again, is not part of the core curriculum, but definitely can provide further education. That is risk factors for overdose. Who are at the highest risk? People who inject, people who are just recently released from incarceration. Local overdose statistics for your state or your city. A review of the Good Samaritan laws. Ways to reduce stigma is another great topic if you have time to discuss with people, and how that plays a role in opioid overdose deaths and people seeking treatment. Medication for opioid use disorder. Harm reduction techniques, CPR, and also you may want to incorporate having individuals practice using naloxone. We use a CPR mannequin, for example, and we have them demonstrate by going through all the steps of how to treat someone who's experienced an overdose. These are all additional things that you can add if you have the time. And you want to make sure that you're tailoring your training to your audience. The training can be done for lay people. You may do training for healthcare personnel. You may be doing training for students. So again, depending on your audience, you may have a quick training or you may have a longer training, particularly if you have individuals that are in a healthcare setting that may look a little different. So determine your time frame for the training. And you can conduct this training in as little as 5 to 10 minutes, and that can be sufficient. and allow participants easy access to naloxone and as much as needed. If someone asks me for more than one, there may be a reason behind that, and being flexible if you have additional naloxone, because we don't know the person's living situation, or that they may be at risk for treating opioid overdose. We want to make sure they have as many kits as they need. So when we look at where are we going to start with our naloxone education, we really want to focus on what are those high-risk populations that are at high risk for seeing or experiencing individuals that have an opioid overdose. So that population includes people that were just recently released from jail. We know that they have a higher risk of experiencing an overdose after stopping from using substances, and then being released from jail puts them at a higher risk for overdose if they happen to use after that limited time frame that they refrain from using drugs. People that are discharged from treatment center, same rationale. Someone that's recently stopped and then goes to use again are at extremely high risk for opioid overdose. Businesses, restaurants, anywhere that has a public bathroom. Again, these are high-risk areas where people may go into the bathroom to use drugs, and then that business owner or those individuals may find someone who's experienced an overdose in the restroom, for example. Family members who live with loved ones who are known to use opioids. We want to make sure that we get them the training that they need since they're in a high-risk situation. Law enforcement officers, fire department, EMTs, again, these are first responders who will be responding to people who have experienced an overdose. We want to make sure that they have the proper training. And then community members who may witness overdose. We know there's certain populations or certain communities where the opioid overdose rate is higher than others. We know there's certain businesses that may be around areas where there may be a higher than usual risk of overdose. So we want to make sure that we get that training to them also. So where do we conduct these trainings? These trainings can be done in multiple settings. I've done it plenty of times in health fairs where you set up a table and you just have like I said, a CPR mannequin where you can do a demonstration. You can do a 5 to 10 minute training right at a table. Any kind of community events where you're going to have a lot of individuals coming through, whether it's a fair, community fair, it could be an event, a concert, where you can set up a table and individuals can come and receive training in naloxone. Community board meetings is another great place where you can provide naloxone training, where you have a large group of individuals that are in one setting and you can provide training at one time. Universities, I'm at a university setting and we actually provide this training to all of our health professional students. Businesses, community-based organizations, and public facilities. Again, it was a very good place to have these trainings because with public libraries, for example, that have a public bathroom, they have a high risk of experiencing someone that may have experienced an overdose. When we think about our public transportation system, transit hubs, again, let's provide training to those personnel that are working in these facilities so that they'll be well equipped to treat someone that's had an overdose. Correctional facilities, social service agencies, and homeless shelters are some of the great settings where you can provide this training, and again, are high-risk areas for people to experience an overdose. And trainings can be in large group settings where you can be able to accomplish 100, 200 trainings and distribution at one time. What I will say, this requires a lot of resources, so you want to make sure, again, you have all the kits available for your training, and you're going to need volunteers. And some of the best strategies that I find is having a large forum or setting where you can present the material, and then having an area where you set up tables, as you can see in this picture, where people come by, almost like a factory, where they pick up their kits. If there's paperwork that needs to be done, it could be another station to do the paperwork, and there could be another station for someone that is available if someone has questions, or there's a mannequin there if somebody wants to practice. That are some of the suggestions if you want to do a large group training. And then another great setting is community events. Health fairs is, like I said, a great opportunity to provide this training to the community. And those can be very quick. As you can see on this table, I have the CPR mannequin. I'm doing a quick training. If you can gather individuals at one time and accomplish, training for a group of people versus doing it one at a time, that's another tip I would advise. But again, just going over those core curriculum items and then doing a demonstration and then distributing the kits to anyone that comes up to the table. One thing I want to keep in mind, just if you're in an area where you know there are individuals in that community speak a different language, you may want to have someone at that table that can help with translation. So what are some of the tips for effectively providing this type of training? Number one, first step is making sure that individuals want the training, letting them know ahead of time what the training is about before you even engage in providing the education. Avoid using stigmatizing language during the training, so avoiding terms such as addict or drug abuser. Avoid using a lot of medical jargon. Remember, some of these trainings we may be conducting for the lay person, so we may have to be conscious about using too much medical jargon where people might not understand. And tailor your training to your audience. There's, for me, I have all different types of training. I have a training that I do for the community. I have a training that I do for health professionals. And I have trainings that are in between. So knowing your audience and knowing how much of that extra content you may want to include. If I train healthcare professionals, for example, I may go into more of a discussion about medications that can help with people with substance use disorder. If I'm training the public, I may go into more about, the stigma behind people who use drugs and ways that we can avoid stigmatizing. So just again, thinking about your audience and really curtailing your training to your specific audience. Make sure you allow plenty of time for questions. People are nervous to administer naloxone, and there are a lot of questions that people may have that might make them hesitant to even take a kit or use a kit. So make sure you have plenty of time for people to ask those questions at the end. And also, they may not think of the questions after training, but providing an email or some way that they can contact you afterwards if they have questions. And during the training, making sure that you're distributing information about online resources, that if you can provide printed material, there's nice brochures that show you step-by-step how to administer naloxone, because in the training, people may forget some of the things that you've covered. So if you can send them home with some materials that can help with retaining the information that you taught. And there's also apps that you can download on the phone. For example, in New York City, we have Stop OD NYC. And these apps are great because they review the tips on how to administer naloxone. They have information on where to get naloxone kits from and medications, to what do you do if somebody's experiencing an overdose, to resources for people who may be living with individuals who are using opioids. So again, another great resource that we want to leave people with after the training. And when you have these trainings scheduled, you want to get as many people to come as possible. So you want to maximize participation. So some of the ways to do that is use social media. We know social media works. So if you have a website, if you have an Instagram page or a Twitter, make sure that on at least a weekly basis or even more that you're advertising your upcoming training so you can get as many people to participate as possible. Old-fashioned posters, flyers you can distribute to nearby businesses, to community-based organizations so that it can help promote the event. And if your state has a Department of Health website, sometimes these websites will have calendars where you can post your trainings on these calendars so the public can be able to attend. And lastly, collaborate with community partners. If you have community-based organizations, for example, in your area, making sure that they're aware of it and having them also distribute the information and invite individuals from the community to attend the training. Sometimes you may want to go to these facilities to conduct the training if that will give you a greater audience. Also, you may want to think about being a naloxone distribution center. And again, this varies state by state, but some states allow community-based organizations or academic settings or hospital settings to actually distribute naloxone. So again, look at your laws and look at your state to see if you could become a distribution center. And it could be as easy as just filling out an application. I just had to fill out a 5 to 10 minute application. A lot of times you have to have someone who has a license, whether it's a nurse practitioner or a medical doctor or a physician assistant that can actually write the orders for the prescription. And you need to have a plan of where you're going to store and maintain the naloxone. There are certain requirements, such as you want to make sure that you have accurate counts each month. You may have to report that back to the state. Certain temperature. You want to make sure that you're reviewing the stock to see if the naloxone expires and what to do if the medication does expire. And most importantly, when you become a naloxone distribution center, there's a lot of tracking, and it's manageable, but you want to make sure that you're tracking how many sessions have you taught in that month? How many kits have you distributed? How many people have reported that they use their kit? These are some of the things that you may have to report to your state on a regular basis. So if you have any questions, please feel free to contact the Opioid Response Network, and they can be reached with this information included on this slide. And we just want to acknowledge that this funding has come from the Substance Abuse and Mental Health Service Administration. And here are some of the resources that were used for this presentation. And I just want to thank you for your time.
Hello everyone, thanks for listening to my presentation today. The title of my talk is Does the Depth of Overdose Education Affect the Likelihood of Naloxone Use? I'm Jermaine Jones. I'm an associate professor of clinical neurobiology at the Columbia University Medical Center and a research scientist at the New York State Psychiatric Institute. My disclosures, the study that I'm going to tell you about was funded by a NIDA grant to Dr. Sandra Comer. I don't have any conflicts to report, and here are my current research grants. Just to give you a bit of background for why we decided to do this study, overdose education naloxone distribution has become a widely used overdose harm reduction tool, particularly in the face of the opioid overdose crisis. However, the dire need for overdose harm reduction led to the adoption of community level OAND practices without much research as to best practices. Controlled clinical research may help us optimize OAND as a tool to combat opioid overdose mortality. Most OAND programs typically include a training component. The training component often focuses on the symptoms of opioid overdose, how to recognize opioid overdose and distinguish it from other medical conditions, and how to intervene, provide rescue breathing, or the administration of naloxone, which is typically provided as a part of these programs. The training component can vary. I've seen studies that have done a training as short as 5 minutes to as much as an hour. The presentation platform also varies across OND programs. I've seen videos, I've seen one-on-one trainings done in small groups, training done in large groups, training done in classrooms, and trainings done on the street. No randomized controlled trials have compared the different methods of providing the training that precedes naloxone distribution. So the goal of the current study was to compare the effects of an in-depth versus a basic OAND training on overdose intervention outcomes. So the primary aim for this study was to determine the extent to which additional psychosocial education can improve overdose prevention training as measured by the frequency of naloxone use as well as overdose knowledge and attitudes. The secondary aim of the trial was to determine the effect of OND on drug use. The trial was conducted at the New York State Psychiatric Institute and also NYU. For this study, we had two training conditions, an extensive training condition and a training as usual. Everyone received a very basic training as mandated by the New York State Department of Health here in New York. The standard training was about 10 to 15 minutes. Participants were asked to return to the study site within a week in order to be randomized to one of the following training conditions, either the extensive training or the training as usual. We stratified the randomization based on sex, the severity of their drug use, as these were individuals with opioid use disorder, and the type of the user. So whether the individual was recently detoxed from opioids, whether they were in some type of agonist treatment, or whether they were not actively seeking treatment for opioid use disorder. Participants randomized to the extensive training condition received about 2 hours of additional psychosocial education surrounding overdose prevention strategies. So the extensive training reiterated a lot of the points made during the brief training. Risk factors for overdose, such as not using alone, not mixing drugs, starting at very low doses, trained individuals in how to use rescue breathing. There was a one-on-one didactic with a research assistant. They learned CPR, and they also did an overdose simulation exercise where they had to practice their rescue breathing techniques as well as how to administer naloxone. Participants who were randomized to the training as usual condition didn't receive any additional education regarding overdose. What they did was they only watched additional educational videos concerning the transmission of HIV and hepatitis C. Following the randomization and the extensive training or training as usual, we followed all of the participants for up to a year. We measured overdose knowledge and attitudes, the use of naloxone, intervention in an overdose event with and without naloxone, whether the participant themselves overdosed, their interest in treatment over the course of the 1 year follow up, and also various heroin use behaviors, such as how much they're using and how they use their heroin, whether they use alone, whether they use with others, whether they use intravenously, intranasally. We collected all of this information at various time points. There was also an additional layer to this study, and that was the potential involvement of a significant other. So, for this study, we required that all participants engage a significant other, which could be a family member, spouse, uh, other type of partner, very loosely defined significant other, to receive one of the training conditions with them. So we ended up with three arms as a part of this study. The first arm was considered just the treatment as usual. This is where the primary participant received the basic training, the significant other received no additional training. The two just came together during the randomization visit and they watched videos related to HIV and hepatitis C. So no additional overdose training. In the first extensive training condition, the primary participant received the extended training while the significant other did not receive any overdose training. And then the third condition, the primary participant received the extended training, but their significant other also received the extended training. So those were the three conditions that we had for the study. Concerning the naloxone intervention outcomes, we only followed the primary participant, who was the individual with opioid use disorder. We did not follow the significant other. So all of the outcomes that I'm going to be telling you about are with the primary participant. We screened about 1,000 individuals for this study. We had 480 individuals attend the baseline visit in which they received the basic training. The big reason why individuals didn't continue at that point is that 82 of those individuals could not find anyone to serve as their significant other to return for the randomized visit and subsequent follow-up. We ended up randomizing 321 individuals to the three training conditions, and with about 100 individuals in each of the three groups. We have data from 314 participants who attended the T0 visit and completed the randomization and the randomized training that they were assigned. 231 completed a T12 visit, so about 74% completed the entire year of follow-up. Over the course of that year, 166 incidents of naloxone use by our study participants were reported to us. 89 unique subjects used naloxone within the course of the year, with about a 96% success rate, meaning that the person that they intervened in the overdose event survived that overdose. Over the course of the 1 year period of enrollment, 17 different participants experienced a non-fatal overdose themselves, with some participants experiencing multiple overdoses. There's no difference between the treatment groups as far as those participant overdose event. About 5 to 7 individuals in each group experienced an overdose themselves, and 2 confirmed participants died within that follow-up that we could attribute to an overdose. What you'll see here is at 30, 60, and 90 days, the likelihood of naloxone use was higher among individuals who received the extensive training. However, over the course of the entire year, the cumulative probability of naloxone use was actually equal or not statistically different among the three groups. There is a more sustained higher effect among those who receive the extensive training with a significant other. However, if you look at the cumulative probability of naloxone use, it's not significantly different across the three groups. The differences in naloxone utilization between the extensive training conditions and the training as usual cannot be explained due to differences in overdose knowledge. What we see in this top panel here are the mean opioid overdose knowledge scale scores, and we see the biggest gains in knowledge after participants received the basic training, so the very short 10-minute training that we provided. After that, we don't see statistically significant increases as a result of the extensive training. And another interesting finding is that these knowledge gains are sustained pretty significantly throughout the year. Additionally, the differences that we see aren't attributable to individuals' competency. Again, like with the knowledge scale, when we ask participants how competent do they feel in intervening in an overdose event, we see the biggest increases after the very basic training with very little additional benefit to the extensive training. But again, we're seeing that competency is sustained. These knowledge gains are sustained. The competency gains are sustained well throughout the entire period with very little decay in either. As an additional aim to this study, we sought to observe for changes in drug use behavior, because one of the biggest barriers to harm reduction practices tends to be the idea that if we make it safer for people to use drugs, it'll change their drug use behavior. They'll feel more comfortable using in a risky way. What we found is over the course of the year of observation, there were not statistically significant increases in drug use. The amount of heroin that participants reported using each day actually decreased. And that's seen as a function of the amount of heroin that they're using in bags per day and also the amount that they're spending on a daily basis for heroin. Another interesting finding from this study was that interest in treatment increased following intervention in an overdose event among our sample. We examined the individuals who utilized their naloxone over the course of the year and found a statistically significant increase in treatment importance among these individuals. That's potentially impactful because we know that among individuals with opioid use disorder and all substance use disorders, ambivalence towards treatment can be very high. So if intervention in an overdose event makes them more amenable to treatment, it may be an opportune time to engage them in discussions about entering treatment. Another interesting finding from this study was that the vast majority of our participants use heroin alone, which is concerning for overdose education and naloxone distribution as a harm reduction practice, because if you primarily use your opioid alone, there's no one there to administer naloxone, and you can't administer naloxone to yourself. In conclusion, this study found that opioid users can learn to recognize the symptoms of opioid overdose and know when it's appropriate to administer naloxone. The knowledge gains that we saw were substantial even after the very basic training that we provided, and they were sustained throughout the course of the year of observation. We also know that opioid users can provide effective overdose intervention. 96% of the naloxone utilizations as a part of this trial were successful. The study found that more in-depth training did improve overdose outcomes. However, the benefits of a more in-depth or extensive training should be balanced against the feasibility of the OND program in its ability to provide a more extensive training and also the acceptability among their clientele. The study found no evidence of compensatory drug use as a result of OND engagement, so it appears that having access to naloxone does not change drug use behavior in a way that is concerning. One of the questions that this study raises is how can OND practices be adapted to isolated drug users? As we saw in the concert diagram, a significant amount of our population use drugs alone and use drugs in potentially isolated environments. And as such, OND may be limited in its benefit to these individuals. I'd just like to acknowledge the study team who completed this investigation, Dr. Comer, the study PI, as well as our co-investigators. And finally, SAMHSA for putting together this series of talks. Hello, everyone. Thanks for tuning into my talk entitled Naloxone in the Era of Fentanyl. I'm Jermaine Jones. I'm an associate professor at Columbia University Medical Center and the New York State Psychiatric Institute. Here are my disclosures and my current research support. Part of the reason why the current overdose epidemic has been so difficult to manage is because of its evolving nature. We started in the 90s with an overprescribing of prescription opioids. Those individuals transitioned to using heroin, so we subsequently saw a rise in heroin overdose deaths, and then the illicit opioid market became inundated with the very potent synthetic opioid fentanyl, which is where we are currently in the epidemic, where the vast majority of overdose deaths are attributed to fentanyl. The majority of overdoses happen in out-of-hospital settings. As a result, there's a potential for significant intervention by non-medical interventions in overdose scenarios. As early as 2012, the US government was finding ways to increase access to naloxone, particularly among non-medical personnel. As a result, there's been a proliferation of overdose education and naloxone distribution programs aimed at reducing overdose deaths related to opioids. They do this primarily by training individuals in how to recognize opioid overdose and then how to intervene using naloxone, the opioid antagonist. There's been several ways in which we've attempted to increase access to naloxone. One has been through standing orders, in which someone without prescribing authority is able to dispense this prescription medication on behalf of someone with prescribing authority. There's been increases in access to naloxone through pharmacies, and there's also been a push to make naloxone over the counter. There's several forms of naloxone that are available. We first went from an improvised intranasal formulation to the one-step Narcan formulation. There's also an auto-injector and also an intramuscular formulation that are available. Overdose education and naloxone distribution programs primarily deal with two types of naloxone, the intranasal formulations and the intramuscular formulations. Over the last 30 years, we've seen a steady increase in overdose deaths. In 2018, moving into 2019, we saw our first decrease. However, the trend quickly resumed to where each year we saw an increase in overdose deaths. Another concerning trend was that we discovered that naloxone access actually decreased as a result of the COVID-19 pandemic. This study showed that there was about a 26% decrease in March of 2020, and the levels of naloxone prescribing have not returned to pre-2020 levels subsequently. So in general, naloxone is a non-selective antagonist of all four opioid receptors. It does not demonstrate agonist activity and lacks abuse potential. Naloxone is rapidly absorbed through intravenous, intramuscular, intranasal, and subcutaneous routes. However, it does have poor bioavailability orally. Naloxone is readily transported across the blood-brain barrier with an onset of action in 1 to 5 minutes, depending on the route of administration. Naloxone also has a half-life of approximately 30 minutes, and of course that depends on the route of administration somewhat. In the US, naloxone is approved for intravenous, intramuscular, intranasal, and subcutaneous use. Intravenous administration is the most rapid and provides the most naloxone exposure. Intravenous, intramuscular, intranasal administration have all been shown to be safe and effective at reversing opioid overdose. In a clinical trial at a safe consumption site in Australia, the investigators compared the efficacy of intranasal to intramuscular naloxone. Among 197 participants, those who received intranasal naloxone were more likely to necessitate an additional naloxone dose, indicating slower symptom improvement concerning their respiratory depression and return to consciousness. The investigators concluded that though intranasal naloxone can reverse an opioid overdose, it was not as effective as intramuscular naloxone. But there are more things to consider. We do know that among opioid dependent individuals who receive naloxone, naloxone can induce opioid withdrawal. A study found that the intensity of the opioid withdrawal was more severe among individuals who received intravenous naloxone compared to individuals who received naloxone intranasally or intramuscularly. So in general, greater naloxone exposure increases the likelihood and severity of opioid withdrawal, potentially resulting in poor tolerability of the treatment. This is sometimes referred to as over-antagonism, and we know that it is a concern because there have been publications which have shown that in emergency settings, naloxone use can result in aggressive patient behavior. Concerns over potential adverse effects of naloxone may present a barrier to OND practices if, in fact, it decreases the likelihood that the intervention will be used. So, another complication or potential challenge has been the inundation of the illicit opioid market with the potent synthetic opioid fentanyl. This study is showing that it was primarily concentrated on the East Coast. However, the West Coast has only been about 3 years behind us in the wave of fentanyl adulteration as it's traveled west. So, how does naloxone compare to this very potent opioid fentanyl? Fentanyl is estimated to be 50 to 100 times more potent than morphine, with some analogs, such as carfentanil, being even more potent than that, up to 10 times more potent than morphine. In competitive binding assays, we do know that naloxone does have a higher affinity for the mu opioid receptor in comparison to fentanyl. And the anesthesiology literature has numerous studies which have shown that naloxone is able to reverse fentanyl-induced respiratory depression. However, the anecdotal reports from overdose education and naloxone distribution programs in which naloxone is administered in out-of-hospital settings suggest that larger amounts of naloxone are needed to reverse an overdose event in which fentanyl is a contributing drug. So, what could be the problem? Naloxone may be less effective at reversing opioid overdoses resulting from large doses of opioids or those with a particularly high affinity for the mu opioid receptor. What happens is naloxone and opioids compete for these receptors. We know that a dose of 1 milligram of naloxone given to someone who's about 176 pounds is going to occupy about 50% of those mu opioid receptors. However, with a drug that is particularly potent, like fentanyl, you may need less receptors to produce overintoxication or to cause an overdose. So as a result of fentanyl's potency, there may also be less time to intervene with naloxone as opposed to with an opioid that is less potent, for example, heroin. Fentanyl has also been shown to produce this curious effect called chest wall rigidity or wooden chest syndrome. What this is a rigidity in the diaphragm and the chest wall. It's not mediated through opioidergic mechanism. It's actually an adrenergic or cholinergic mechanism that produces this effect, and it's unique to fentanyl as opposed to other opioids. And we know, again, from the anesthesiology literature, that wooden chest syndrome in itself has the potential to be fatal if airways aren't properly managed. So I found this figure from a critical care website showing the risk factors for wooden chest syndrome. And it's high doses of fentanyl, lipophilic opioids like fentanyl and its analogs. And by lipophilic means opioids that are stored in the fat, um, being older, and also concomitant medications that may modify dopamine levels. So, what could be a potential solution now that we are in a scenario where overdoses are primarily attributed to fentanyl? One could be higher doses of naloxone. The standard intranasal dose is about 4 milligrams. We do know that there is an 8 milligram formulation currently available, or has been made available recently. However, again, we are balancing effective use of naloxone versus the probability that the naloxone is going to be used altogether. You're balancing effective overdose reversal versus inducing opioid withdrawal. And it may seem like a no-brainer, choosing between saving someone's life and making them sick. But at a hospital setting where you're asking an individual to voluntarily administer naloxone to someone who they may not know, that is a very strong consideration and may lead to decreased naloxone use or make people more resistant to using naloxone. We could potentially also encourage intramuscular use as opposed to intranasal use, because there was a study that showed that it was a bit more effective. But again, we're balancing effective use of naloxone versus the likelihood that it will be used. In our research, we've shown that people who use drugs who aren't familiar with intravenous routes of administration or who don't use IV, they're often very uncomfortable with syringes. And also, getting them to carry a syringe for intramuscular use may be problematic. And even more so, asking someone to inject someone with a drug into their arm versus asking them to push something into the nasal cavity may be very different. So there's the potential that you could decrease the likelihood that the medication is going to be used. Another potential solution is that we give more standard doses of naloxone. There's not a lot of guidance as far as how much naloxone is given in overdose education and naloxone distribution programs. The standard very up until recently was just 2 doses. Do we need to give more naloxone? Also, should we consider altering our recommendations surrounding naloxone administration? Maybe we should be teaching people to administer naloxone sooner. Maybe we should shorten the time between administrations of naloxone if someone is unresponsive to a first or a second dose. I think there's a lot of potential questions to be asked and a lot of research that needs to be done. Just to acknowledge SAMHSA for putting together this series of talks, and thank you all for listening.
Communities across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.